Mr. Chairman, Co-Chairman, thanks organizing committee for giving me this opportunity to give this talk. It's always difficult to give the first talk, and it's difficult also to share the session with a very well-known IBD expert in this field. Hopefully I can give some clues about epidemiology of inflammatory bowel disease in Saudi Arabia. We'll talk about an overview of IBD epidemiology in Asia, or namely, honestly, prevalence of IBD in Asia and Middle East, overview most recent studies in Saudi Arabia, and then we'll talk about some of the new data from our Saudi IBD registry. Describing the epidemiology of IBD is important. First of all, appreciating the public health burden it causes, planning appropriate health services, and moreover, careful descriptive epidemiological studies might offer clues to etiology of these diseases, especially in countries where Crohn's disease, especially Crohn's disease, just hit that country. This is the global map of Crohn's disease incidence, where you see the dark blue. The darker blue is where the incidence is high, and you see it's in Northern Europe and Northern American, and most of the other countries used to be in the light blue. In Japan, cumulative number of IBD has risen 3 times since early 1990s. In Seoul, the same thing for Crohn's disease and ulcerative colitis, but most of the countries, definite surge of specifically Crohn's disease. Malaysia, Singapore, India, and recently also publication from Kuwait, Lebanon, Iran, and Turkey. How about Saudi Arabia? It started from what's being called no cases until Mukhtar published the first 2 cases of Crohn's disease, and Harper and Spitzer reported the first 28 patients with Crohn's disease between 1976 to 1994. So it takes him at about 18 years to have 28 Crohn's disease patient in King Faisal, which is a referral center. In 2003, Al-Ghamdi reported the first study about Crohn's disease, where they reported 77 cases from 1983 to 2002. Again, it's almost 20 years. This is a tertiary medical center. It's a university center. The mean annual incidence of disease over the first 10 years, which is 1983 to 93, 0.3 per 100,000, and it's been jumped to 1.66 per 100,000 over the last 10 years. More recently, May 2012, Dr. Mohammed Al-Fadda published this study from King Faisal. From 1970 to 2008, 197 Crohn's disease and 115 ulcerative colitis. Mean age was 24 for Crohn's disease, predominantly males, and for ulcerative colitis 28 and mainly predominant females. 9 patients with ulcerative colitis developed colon cancer, but more importantly, this is what we see in Crohn's disease with these. Before 1980s, almost nothing, and then there is a definite jump of the prevalence of Crohn's disease from 1990, specifically from 2000. And more recently this month in Saudi Journal of Gastroenterology, an outpatient status. This is a private outpatient clinic. Mr. Mohammed Al-Farrah and his group reported 693 IBD patients from 1993 to 2009, reviewed, constituted 238 ulcerative colitis. However, there is a definite also 455 Crohn's disease. UC was thought it's steady throughout the years. However, there is a definite surge of Crohn's disease over the years. How about, this is a preliminary data, by the way. It's Saudi registry About 5 centers so far, mainly in Riyadh, participate in the study. 2009, inflammatory bowel disease information system, which is known as IBDIS. This is the ECHO website for registration of IBD. It's a web-based documentation system, include demographic, disease location, behavior, age. Almost, it's a 9 blocks, almost considering all Montreal classification based on the age, the diagnosis, and age, and location and behavior. I have to say there is always difficulties, especially with registries. One of the difficulties, each patient almost take 20 to 30 minutes to accomplish. So it's always difficult to ask people to participate, especially when there is no much of financial support and there is no much of also research assistance. So it's always very hard really to do. Inconsistency also of reporting the features, which is a well-known fact indeed. Montreal classification, even among experts, which has been actually shown in some studies. Also, it makes this always difficult, and always an expert has to review all the data to make sure these data are real, especially when you talk about the behavior. If this is a penetrating disease, if this is a structuring, always it's a difficult. And unfortunately, sometimes you will be faced by many incomplete data, which unfortunately you cannot use. Case definitions, lucky enough, is a very actually strict diagnosis of Crohn's disease, standard clinical, endoscopic, radiological, histological criteria based on the last ECHO guidelines in 2010. This is actually what we have seen, what we have so far. 456 Crohn's disease patients, 58 were males, which is predominant males, 10 to 7, which is being actually reported before. It's consistent with most of the Saudi studies, although it's a bit different from the Western country. Mean age is a bit earlier. It was 25 years. There is a range from 5 to 75 years. There is also another important finding, duration from symptoms, from the start of the symptoms to you have the diagnosis made, it's 11 months, which is consistent with most of the recent data. There is a study in Copenhagen where they actually compare the before 1970, it used to be 2.2, but nowadays almost 7 to 9 months, which is almost the same, which is probably about the more awareness of the disease and availability of the test in this. Duration of the disease is 40 months, so it's probably still young Crohn's disease patients. Most of this is the CRP level at the start, at the day of entry, which is 19.5, which tells you how active is these diseases. Family history is 10%, which is consistent with Western, although there's, from Kuwait, it's shown 20% family history of IBD, namely Crohn's disease or ulcerative colitis. There is a 21% prevalence of granuloma, extraintestinal manifestation, 31%, and 2% of our patients indeed had complicated by DVT, which is a bit higher than what's been reported in the literature. This is a very nice graph show you there is only one peak here of our patients, which is almost 15 to 30 years. We don't see another peak, which is most of the actually new data now is showing probably the same thing, and the secondary peak now probably disappearing from the map. Distribution of age of patients at diagnosis according to sex, males, females, or the behavior, B1, B2, B3, structuring versus non-structuring versus penetrating, showed indeed no significant association. This is the age at diagnosis according to Montreal classification. As you can see here, this is the age from 17 to 40. then 16 years, then people above 40. I have to say here, most of actually the reported cases are from adult gastroenterologists, so that might actually decrease the spot, which is below 16, because of lacking of pediatric cases, although they range from 5 to 76. Location according to the Montreal classification, and if we just a reminder of Montreal classification, this is ileocolonic, which is L3, which is L3, which is the most common. A terminal ileum, which is any patient has involved with the terminal ileum and the cecum. And then this is colonic, only isolated colonic, which is the least common, which is almost consistent with the previous studies. Again, disease behavior or location in relation to age at diagnosis show no significant association. How about the behavior according to the Montreal classification? Non-structuring, non-penetrating, 40%. Most of the reported actually, in at least previously reported by Mohammed Al-Fadda, showed about 70% inflammatory. Also from Kuwait, almost 60% were inflammatory. In our study, this is non-structuring, non-penetrating, only 40%, and 30% structuring and penetrating in 28%. This, by the way, being reviewed 2 times by IBD expert to make sure the behavior, especially the Montreal classification, being validated by an expert. Patients with structuring behavior were found to have more granuloma. This has been also published before by Chinese studies. Significant association between terminal ileal involvement and structuring disease with a p-value 0.003 being shown, and this is also being shown in most of the reported studies. Also, there is an association between left side colitis and penetrating disease with a significant p-value in this. How about perianal disease? It's present in 33%. It's almost exact match the same in Northern Europe and Northern America. Perianal fistula in 14%, where 66 simple fistulas and 33% had a complex fistula. There is a significant association between perianal fistula found more in the 80 group, which is 17 to 40, when we compare them with patients above 40-year-old. The course of the disease, despite having this, I would probably say, aggressive behavior, more structuring and more penetrating, the course of disease opened the time of the registration. This patient already on medication. 3.8 had a chronic continuous activity, 19.3 had frequent relapses, and 77 had infrequent relapses, which by definition less than 1 relapse per year. However, these probably indicate our patients still, probably because of the younger duration of this 40 months, they still respond very well to the medications. Patients with perianal fistula were found to have an aggressive course when compared with those without. Steroid use, which I think it's a very important data to know. 19% never been exposed to steroid, whether they have a mild ileal or sometimes they could have a very aggressive disease and could be started on biological therapy to start with. 47% been exposed to steroid once, 17% had been exposed to steroid twice, and 16% more than 3 times. Response of steroid, 83.5, they respond very well to steroid. There is 12% were steroid dependent and 11 patients were refractory to steroid. How about ulcerative colitis? 386, I mean age was 30 years, 46% were female. This is the disease extent, so almost half are having pancolitis. And then we could have only about 25% of our patients had proctitis. Course of the disease, most of these patients indeed, they respond very well even to 5 SAs compared to Crohn's disease. And some patients can have mild disease, and very few patients have severe colitis. More than no remission in very few patients. However, most of our patients has less than 1 relapses per year. So I conclude here, Mr. Chairman, Co-Chairman, that there is a definite surge of Crohn's disease in Saudi Arabia. I would probably call it from reported cases to thousands of cases within few years. Probably I can say maybe the year of 2000 or maybe 95 is probably the year. Although Crohn's disease behaves aggressively, more structuring, more penetrating, they're still responding very well to the medical treatment, probably with a short duration of the disease. Although half of our patients also has an extensive colitis, most also were in remission on 5-SA. There's still many questions not answered. What's happened? What happened to the surge? If this is because of increased public awareness of physicians, awareness, is it because of availability of tests, or there is a definite surge and there is probably removal of some factors, protecting factors, and probably introducing of other risk factors. And thank you very much.
Thank you very much, Dr. Abdulrahman.